We are so lucky in Australia because the TGA, Therapeutic Goods Administration, has approved a specific 1% testosterone cream for use by postmenopausal women with low libido. So we are actually leading the world in this space.
Hello and welcome to Thriving in Menopause, brought to you by Prevention Magazine. I'm your host, Zoe Meunier, the editor of Prevention. Today, we're diving into a topic that's often overlooked, but one that has the potential to change the lives of many women during and after menopause, and that's testosterone therapy. Testosterone is obviously usually thought of as a male hormone, but it plays a vital role in women's health too. To help us understand how it works, why it matters, and what the evidence really says, I'm joined by Professor Susan Davis, a leading authority on women's hormone health and one of the world's foremost researchers into testosterone therapy for women. Professor Davis, thank you so much for joining us today.
Well, it's great to be on. Thank you for having me.
Okay, so let's start with the basics. For those who aren't familiar, what role does testosterone play in women's health, particularly during and after menopause?
So testosterone is a really important female hormone. It's made in the ovaries, and it's also made from pre-hormones released by the adrenal glands. Its role in the ovaries is that within the ovaries, it is converted into estrogen during the ovulatory cycle when you're making an egg. And that creates very high estrogen levels in an ovary for the growth of an egg. So testosterone is converted to estrogen. But what's not used by the ovary spills over into the blood circulation and circulates around the body. Now, we know that there are receptors to testosterone. We call them androgen receptors. They exist throughout the body. They're in muscle, bone, brain, blood vessels, fat, everywhere. And testosterone indeed acts on those receptors, but also it gets converted into estrogen, which then acts in parallel with testosterone throughout the body. So it is an important hormone in its own right, and as a precursor, what we call a building block for estrogen production.
Right. And then what happens to testosterone levels when we go through perimenopause or menopause?
Nothing.
Right.
There is not a single study, even with the most precise measurement of testosterone, that has shown that testosterone blood levels change at menopause. That is a myth.
Right. So it's not like our friend estrogen.
So what we've shown in very large numbers of women, and we've measured testosterone blood levels in thousands of women, and we have shown that between the ages of 18 and 60, testosterone levels slowly decline. The greatest decline is in women in their mid-30s to their mid-40s. That's when we see the most rapid change. And then the decline sort of plateaus out, slows down. So imagine like a roller coaster from 18, it's a bit of a decline, then there's a steeper roller coaster going down, and then you get to your mid-40s and the roller coaster starts to slow down and keeps going slowly down till 60, and then it starts going up again. Oh. So women in their 70s have similar blood testosterone levels to women in their 20s.
Wow, that's interesting.
So most people don't understand this, and there's a lot of misinformation wandering around the internet. And it's not a menopause thing, it's an age thing. But if you go on the internet, even the Cleveland Clinic says menopause is a cause of low testosterone. And that's so untrue. It's aging.
Yeah. Yes, we can't blame everything for old menopause.
We're trying to understand what role why does it increase in older women? Why does it start going up again?
Yeah, that is very interesting. Is there any, I guess, research that if women did go on it as a postmenopausal woman, did go on testosterone therapy, and then, as the surge goes up again, is there then a risk of then perhaps having too much testosterone?
Because testosterone does increase from the age of 60 approximately, there is the potential that if much older women are adding in testosterone, it might be more likely to have adverse effects. We simply don't know because most of the studies so far of giving testosterone have included women up to the age of 70. But what we have seen is that in women over 70, women with the lowest levels of testosterone have a doubling in the risk of cardiac events. And we're trying to understand that.
Right. That's interesting.
So is it an indication of better overall health? Or does testosterone play a role? We don't know, and we're looking at it.
So obviously testosterone is often referred to as the male hormone. So apart from producing estrogen, what does testosterone do for us? Why is testosterone so important?
Well, it's probably not that as important as people are making out. So there are individuals whose body doesn't respond to testosterone. So they have what's called androgen insensitivity. Their receptors to testosterone are insensitive to the action of testosterone. And these are perfectly normal, healthy people. You don't have to have testosterone action to be healthy. And we've done studies looking at, is there a relationship between low testosterone and any clinical feature? Is there a relationship between testosterone and muscle mass, muscle performance, sexual function, mood? We've looked at this in lots of women and we can't find an association. So there's no testosterone deficiency syndrome. And people who are saying there is are not sharing what is known.
Right. Okay.
It does play a vital role to a degree because even in people whose cells are not responsive to testosterone, testosterone gets converted into estrogen. So it gets converted into estrogen in bone, for example. So testosterone is converted into estrogen by an enzyme called aromatase. There have been 4 men described in detail who do not have that enzyme working in their bodies. And one we characterized in detail had severe osteoporosis.
Right.
He was given testosterone and that did not improve his bone health, his bone density. But when he was treated with a 25, a very low dose estrogen patch, his bone density improved.
Right.
So a critical role for testosterone is its ability to be turned into estrogen. And that's really important in bone health and other parts of our bodies. So I think a lot of people who are on the internet who are talking about testosterone don't understand testosterone.
Testosterone has traditionally been left out of the conversation when we talk about hormone therapy for women. Why do you think that is? What role do you think it plays?
Oh, look, we showed, 30 years ago that for postmenopausal women with low libido, testosterone can improve libido in a significant proportion of women better than placebo therapy. And that has been shown in large studies over and over again. It's irrefutable evidence. When we've looked at what proportion of people respond, it's about 60% of women treated respond. So not everybody's going to respond, and that's because testosterone is not necessarily the issue for a lot of women. It's relationships, it's stress, it's whatever. But about 60% respond, and the treatment is more effective than placebo. That's important. We've known that for years. But what has to be understood, it's pharmacotherapy. It's not treating a deficiency. It's pharmacotherapy.
Can you elaborate on what that actually is?
It means that in the studies, the very big studies, the largest study I did was 800 women who did not know if they were getting testosterone or placebo. And the requirement to be in this study was low desire that caused the woman distress sufficiently that she wanted to do something about it. You didn't go in the study because you had a particular blood testosterone level.
Right.
We weren't treating low testosterone, we were treating low desire. That's incredibly important. So we weren't treating a deficiency, we were treating a symptom.
Yeah, so as you said, for some women who have other issues going on, it's not going to be helpful. So is there any way of sort of being able to say this is the kind of symptom or like the presentation of low libido that would respond well to this therapy?
Not really. I mean, obviously, patient walks in the door, 52-year-old woman says, I'd rather read a book. I don't want to have sex. I used to be interested, not interested anymore. But then you find she's having hot flushes and night sweats and sleep deprivation. So the first thing you're going to do is treat that. Because obviously, if you feel like rubbish, you're not going to feel like sex, generally. Has she got vaginal dryness and is sex causing pain? Then you don't want to have sex. You don't want to do something that's painful. So you treat that. Now, assuming you've treated those things, or those are not issues, then I would always offer a patient a trial of therapy. Because if I could do some magical test that's going to tell me who it's going to work in and who it's not going to work in, I would do it. But there's no magic test. And so I'm often surprised by who it works in and who it doesn't work in. So I try to be non-judgmental and offer people a trial of therapy. And I explain it is a trial of therapy.
Yep, for sure. So, you've obviously been a real pioneer in this space, as well as low libido. Have you noticed or have you discovered any other menopause symptoms that testosterone therapy can help with?
So patients, the first time I started prescribing testosterone or treating women was when I started in a menopause clinic, showing my age in the 1980s, right? And with that, over the next few years, patients used to tell me they felt better. So we started including wellbeing questionnaires, validated wellbeing questionnaires in our studies. And as I said, women are getting testosterone or placebo, and they don't know what they're getting, and we don't know who's getting what. And what we found is absolutely no difference in wellbeing in response to the treatment. So while a lot of women will tell you they feel better, it was life-changing, I had more vitality, but in placebo-controlled trials, and the largest was 800 women, we saw absolutely no difference between the women who got testosterone and women who got placebo. So we've not seen any meaningful outcome. The studies looking at things like cognitive function, muscle mass, muscle function, bone health are either too small or too fragmented or too poorly done or too short to draw conclusions. So I would say the jury is out. Mm-hmm. Right now we're doing one large study looking at bone health over 12 months and another large study looking at really sensitive markers of muscle power, muscle function, muscle mass. And so I'm open to finding out that there is or isn't a benefit. But until we know that, we shouldn't be telling women that there is a benefit.
Mm. Now, let's talk safety, because understandably that's something many women are concerned about. What does the research say about the long-term safety of testosterone use in women?
Well, firstly, there are no long-term clinical trials.
Mm.
So the largest safety study we've done was out to 2 years. And if you use a dose of testosterone that achieves blood levels similar to what is seen in premenopausal women, there doesn't seem to be any signal of it being unsafe. We do see a small increase in acne and a small increase in body hair growth. And I'm not talking about hirsutism, I'm talking about body hair growth. So some women start shaving their legs or under their arms. But we've only gone out to 2 years, and I'm specifically talking about doses that are within the female reference range, but a lot of women are getting much bigger doses out in the general community, and we have no data for the safety regarding that.
Yeah, so let's talk about that. How is testosterone typically prescribed? Why are women using these larger doses or male formulations?
We are so lucky in Australia because the TGA, Therapeutic Goods Administration, has approved a specific 1% testosterone cream for use by postmenopausal women with low libido. It's now also approved in New Zealand and South Africa. Everywhere else in the world, people are having to use either compounded therapies or male formulations and trying to measure out little fragments of a male formulation with a great deal of inaccuracy. So we're actually leading the world in this space.
Wow. And why then are some women still sort of opting for, as you mentioned before, having larger doses?
Well, I think there are clinicians who don't even understand that we have a female approved product available. And I think a lot of women don't know that as well. And that this has been shown to have effectiveness and a good safety profile. And we would be encouraging doctors and women in the community to opt for the TGA approved product rather than compounded products, which are a bit of a best guess, and male formulations, which are very difficult to measure out.
Right. Okay. And what about access? How easy is it for women to actually get a prescription for testosterone? Like, are there any barriers to access that we need to be aware of?
The barriers are doctors not having the skill set to feel confident about prescribing. So I have treated women, got them stable on testosterone, they're happy, it's working for them, discharge them back to their GP, and then I get a text through to me, my GP is refusing to prescribe it. And that makes no sense. It's TGA approved. There's no restriction on prescribing. All you need to do is write the script. The woman knows how to use it. And you just every year just check in on the blood level. The only reason we do a blood level, the only reason, is to make sure that in error that the patient isn't overusing the cream.
Right.
Not to check that she's got the right blood level. That's a complete nonsense. But rather to check that by mistake she's not applying too much and to keep an eye that she doesn't end up in a situation where she's overusing it and gets side effects of masculinization. So that's the only reason we do a blood test.
So why is it that doctors have this fear or this desire to stop treatment?
As I said earlier, it's not about testosterone, it's about sexual health. It's about not knowing about it. And testosterone's a big bogeyman topic, so they're not confident. They've never heard of using this, perhaps. It's hard to prescribe a drug that you're not familiar with, so we're trying to teach people more about it. And again, I think a lot of younger doctors just cannot understand women in their 50s and 60s and even 70s are sexual.
Yeah.
My grandmother doesn't have sex, My mother doesn't have sex.
Yes, you're probably very right there. So obviously testosterone is now kind of getting promoted in some corners of the wellness industry and on social media. And you've talked before about checking that women aren't either intentionally or accidentally overusing. What are some of the concerns around overuse or misuse? Like what could actually happen?
Let's do misuse first. If you use testosterone in a therapeutically evaluated dose, you're using it safely for low libido, it's effective, that's fine. But let's say you've got low bone density and your doctor tells you you can use this and it's going to improve your bone density, or you've got low mood and you've told this is going to improve your depression. You're basically prescribing something that may not work, where the woman should actually be on an effective therapy.
Yeah.
So the woman's missing out against being treated properly for her condition by maybe a belief or an anecdote that it might work. That's one thing. Then women spending money on a treatment, it's still sort of $35 a month. They're spending money on a treatment that may not work for them. So I think that's misleading the patients. So that's my concern about misuse. In terms of overuse, some women become tolerant to higher and higher doses. And over the years, I've seen women who have ended up on quite high dose testosterone. And when you try and get their dose down, they're actually, it's like a thermostat. Their brain thermostat's gotten used to the high dose. And when you start to wind it down, their mood does change. But I've seen patients I've tried to get off because they've got an enlarged clitoris.
Right.
Or they've got voice changes. Now, the voice change and clitoral enlargement do not reverse.
Right.
So I have seen over the years women with dramatic changes in clitoral size, which is very unpleasant, very uncomfortable, and you can't reverse that by just lowering the dose. It's not that easy. So there can be adverse effects, and no one's talking about them. The other thing that is we saw in all the studies where women got a female appropriate dose is there is a tendency to about 1 to 1.5 kilos in weight gain in some women.
Okay.
And women do need to be warned of that. That could be fluid retention, not just gain in muscle or fat, but there does tend to be that slight weight gain.
Okay, yep. I'm sure women would want to know about that, going in forewarned. So for women listening who are curious about whether testosterone might be right for them, like what should they do next? What kinds of questions should they be asking their doctor, or where should they be kind of, I guess, going to get the right treatment?
The first question is, if you have low libido that bothers you and you're postmenopausal, it may be helpful. If you have menopausal symptoms that are affecting you, like mood, flushing, sleep, you should address those first, because I have often seen addressing those will improve your overall well-being and therefore your libido. Be honest with yourself. Are there relationship issues? Deal with those. And I don't stop women from going on testosterone if there are relationship issues, because sometimes the relationship issue is a result of the woman's low libido causing a problem.
Yes.
So I don't say, oh, you've got disharmony at home, I'm not going to treat you. And treat vaginal dryness. Less than 10% of women, postmenopausal women, are using vaginal estrogen, yet we know over 50% have vaginal symptoms. It's safe, it's effective, it reduces urinary tract infections. So women should use it. And then go and talk to your doctor. And I'd also add, this is not just about partnered women, and it's not just about women in heterosexual relationships. I treat plenty of women with testosterone whose sexual function is different to their female partner, and it bothers them. And I treat single women who say, how am I ever going to find a partner if once I connect, I have no interest in sex? So I don't believe sex is about partnered heterosexual women. I think it's about people.
For sure, for sure. Now, one point that I would like some clarification on, you often mention postmenopausal. So is testosterone therapy not recommended for women who are in perimenopause? Do you have to actually have gone through, officially be in menopause?
I think it's a really important point. There are no studies in perimenopausal women. So, and the reason is I've agonized over this for a range of things of looking at perimenopausal women. And we have a paper being published this weekend that is all of 5,500 Australian women, what happens to them between early peri, late and post menopause. And the problem with doing studies of perimenopausal women is that everything's changing every minute. So you could think that you give treatment X for whatever, even hot flushes or mood, and one particular patient improves. Well, is that because she's gone back into her estrogen being made? Her ovaries started working again. I mean, the ovaries are going on and off and on and off and on and off. So what you give testosterone, what are you going to find? But I would not deny a perimenopausal woman testosterone therapy. It's just we don't have the data to say it works.
Gotcha.
I suspect it does work.
Yeah.
Premenopause is more difficult because there's very little data. We've done the two main studies in the field. Our first study of women in the late premenopause, age 35 to 45, with regular menstrual cycles, no hot flushes or night sweats, we did a study of 34 women and it looked like there was a benefit. We then repeated that in 270 women and couldn't reproduce the data. So our plan is to do another study in premenopausal women that's sufficiently large to see if there's an effect. But presently, there's not enough evidence that you would treat premenopausal women with testosterone therapy. I mean, I don't think we should say that's a blanket that doesn't work. We don't know.
Right. As an expert in the space, what do you hope that the future might bring in terms of women's hormone therapy options here in Australia?
The biggest problem we have at the moment is that the most information we have about HRT or MHT, whatever you want to call it, comes from the Women's Health Initiative study or other studies that have been done with oral estrogen and progestins. And everybody is extrapolating both the benefits and the risks to the therapies we have today. So, for example, in the Women's Health Initiative study, women who had a hysterectomy who got estrogen only and were aged 50 to 59 had a reduced risk of breast cancer and heart disease. But we don't know if that's specific to the particular product that was used, pregnant mare's urine, but everybody's extrapolating it to the products we're using today, patches and gels. There is no data. So what I hope is that we have more research because at the moment, people are acting on beliefs, not science.
Yeah. Well, it sounds like you're very active in the space and doing plenty of research for us all. So we're very appreciative. Is there any research that you've done over the past decade that really stuck out to you as being really significant?
I think the biggest study we did, which was really a review of the literature, that we reviewed the world literature on testosterone in women, and that showed the benefit on low libido, irrevocably, as I said, and that resulted in the global position statement, and that resulted in the improvement in the approval of testosterone for women in Australia, and I think it may lead to the approval of testosterone for women in countries like the UK and possibly the US in due course. That's been dramatic. It also showed where we don't know benefits or risks and where we need to do the research, and that's led to the research that we're doing now.
Really an evolving space. It's quite fascinating. Well, Professor Davis, thank you so much for sharing your time and expertise with us today.
My pleasure. Thank you.
And thank you for our listeners for joining us as well. Don't forget to follow or subscribe so you never miss an episode. And if you found this helpful, please share it with a friend. Meanwhile, don't forget to pick up a copy of Prevention Magazine. I'm Zoe Meunier. See you next time.